periprosthetic fracture in total knee arthroplasty is a growing concern, and it is the third most common cause of revision of total knee arthroplasty, and 6% of all revision total knee arthroplasties are due to periprosthetic fracture. And it's increasing both in primary revision total knee arthroplasty, with increasing age also it is increasing in primary as well as in revision arthroplasty. Out of all periprosthetic fractures, supracondylar femoral fractures is the commonest, and I am going to focus on the supracondylar femoral fractures only today. There is a Cecil-Rorabeck classification which holds good. So type 2 is especially displaced where the components are intact, it requires some kind of internal fixation, and type 3 when it is displaced with loose components, it requires some kind of replacement. This is an important diagram one must remember. The margin is the anterior flange of the femur. So if your fracture is distal to the anterior flange of the femur, it requires replacement. If it is proximal to the flange of the femur, it requires some kind of fixation. And if it about 1 or 2 inches above the flange of the femur, then it requires a nailing procedure. And in between it requires a nailing or a locking plate, or both nail and the plate. And if it is distal to to the flange of the prosthesis, then it requires a revision procedure. So the considerations here: what is the distance of the fracture line from the implant? What is the knee design which has been used, whether it is a PS or CR type, and whether it is a open or closed box type of implant. So if it is a closed box type of implant, then your nailing procedure is out. Only in open box type you can do the nailing, and you need to know what is the width of the box. That will depend what is the diameter of the nail, and your width of the box has to be more than the diameter of the nail in order to do a nailing. Whether the implant is stable or unstable, what is the available bone stock, whether there is any comminution, and what is the pattern of the fracture. Whether to go for a single plate or dual plate, always dual plate or nail plate combination is better. It is safe and biomechanically sound, because the medial plate helps you to reduce the shear forces on the medial side, and a long lateral plate or with a large working plate helps you to decrease the stress per unit area on the lateral side. The key points here that you achieve a good reduction, and there should be option of putting polyaxial screws in different directions. The plate should be long enough with a good enhanced pull strength, and always leave the metaphyseal area. Do not put any screws in the metaphyseal area which is usually comminuted. First case, 72 years old female, right total knee arthroplasty in August 20, supracondylar fracture in July 21. That is a periprosthetic fracture. As you can see here, it is just at the proximal to the anterior flange of the plate. Plating was done a long lateral plate without any metaphyseal screws, and a medial plate to reduce the shear strength. That is 1 year follow-up of this patient, and a good outcome of this patient. Now tips for nailing: if you are doing a nailing procedure, entry point should not be too posterior. You should have a 5 to 10 degree anterior bend in the nail, and change in the liner if it is needed. And if you put the entry point is little posterior, then there will be hyperextension deformity like this. So avoid valgus and hyperextension in a nailing procedure. The AO recommends the entry point should be at or anterior to the Blumenstadt line. Then your nailing procedure will be good. So now AO has come out in different types of the nails, which are especially for the periprosthetic supracondylar fractures. They are expert retrograde or antegrade femoral nails, which has got a 10 degree nail bend anteriorly to help to maintain or to match the anterior femoral bow. And also it has got AO nail supracondylar periprosthetic fracture, where there is the option of putting multiple screws there. So in case there is a metaphyseal comminution or osteoporosis, these screws will have a better hold. And this is a second case, 87 years old female, type 2 periprosthetic fracture, inadequate, fixation, only lateral plate has been put. 5 months showed non-union, which was augmented with a nailing, and 13 months down the line fracture got united. Finally, case 3, 53 years old female, type 3 fracture, when bones are inadequate, then you have to do a distal femoral replacement prosthesis, and that is the follow-up of this patient with the distal femoral replacement prosthesis on the left side. When you are doing this procedure, remember that you have to maintain the rotation and the length of the leg. You have to address this thing during surgery. Now there is a unified classification for the complex periprosthetic fractures. especially interprosthetic fractures when there is a hip replacement and knee replacement. You have to put a long plate like this right from the trochanter towards the lower third of the femur, and sometimes you have to augment with a strut graft medially, especially fibula graft, so that healing is better. And type E fracture, when each of the two bones have been fractured, it can be treated appropriately with fixation or a revision arthroplasty. So take home message, dear friends, always involve your trauma colleagues in this kind of fixation, recognize the fracture, reduce the fracture splint and get the CT done. Intraoperative bone quality and prosthesis stability will help you to take a decision whether you are going to fix or going to replace, and protect these fractures, do a graduated mobilization, and always treat osteoporosis. Never forget to treat osteoporosis after the treatment of the fracture. I thank you for a patient hearing.